Yeah, I gotta duplicate this. I'm sorry to keep you guys waiting. Just give me like 30 more seconds. All right, so we'll just quickly run through what I had in the video, maybe not like in detail. All right, so this is the Dr. Sutherland's lecture on triacylglycerol and lipoproteins. So basically the sources of lipid in the plasma. All right, so basically from your diet, if you eat maybe like a hamburger or whatever, so there's going to be fats in there, and the free fatty acids, once it gets down to your intestine, are able to cross through the intestinal epithelium, and once they get into the enterocytes, they can reconverge and form triacylglycerol, right? Now that triacylglycerol, right, in concert with cholesterol, can be packaged with apoprotein B48, all right? And this is how you form your chylomicron, right, in your intestine, right? And the chylomicron is going to enter your lacteal, right? Then from your lacteal, it's going to move through what? Your lymphatic system, right? Then from your lymphatic system, is dumped into your circulation, right? Okay. So now, this is the thing you guys have to know, all right? So apoprotein B48, all right? It's specific to your intestine. All right, and it's specific to the chylomicron. All right. So the notes that you guys see here, I will post it on Facebook. So so you guys can maybe try to like memorize while I'm speaking. I don't know if that. So I think it'll be more effective for you guys to try to memorize. Maybe try to come up with questions that you can ask other people. So I will pause and then you can ask someone. So try to make it a little bit more interactive. Okay, so the chylomicron goes through your lymphatic system, it's dumped into your circulatory system, right? In your circulatory system, it's going to move around, and different cells are able to remove free fatty acids from the chylomicron, all right? And at the end of the day, it's going to head to your liver and to your adipocyte, all right? So the first thing is the chylomicron in the plasma, meaning in your blood. So plasma, blood, right? The chylomicron in your blood, right? Coming from the diet, the triacylglycerol coming from the diet. Now, in your adipocytes, right? So the free fatty acids that are in your adipocytes, well, they're first of all in the form of triacylglycerol, right? Now, that triacylglycerol is going to be broken down by your hormone-sensitive lipase, all right? And we're going to get free fatty acids, and it would also be broken down into glycerol as well, but that's by another hormone. So like hormone-sensitive lipase only breaks down triacylglycerol to a certain point, and then another hormone acts, and then you'll eventually get glycerol. But the free fatty acid inside the adipocyte is going to diffuse out, right? But the thing is that it can't just like move in circulation like that, right? It has to be bound to albumin. So once it's bound to albumin, then it heads to your liver. All right, so what have we seen so far? We just saw that, yeah, sorry, go ahead.
What's that?
Free fatty acid.
Oh.
Free fatty acid, sorry about that.
Okay.
The next.
Oh, I'm sorry.
Oh, okay, no. I'm reading, I'm like,
Yeah, it's a
that's
typo.
what I thought it was, but I didn't want to assume anything.
Thank you. It is a big typo, man. I'm sorry about that. All right, if you guys see anything, please ask me. Like, I make a lot of mistakes, but you could always correct it. Okay. So we just saw the chylomicron entering circulation, right? Now we just saw the free fatty acid from the adipocyte bound to albumin, right, entering into circulation, right? So these guys are going to be headed where? They're going to be headed to what? Your liver, all right? So once the chylomicron and the free fatty acid bound to albumin goes to the liver, All right. Now, what the liver is going to do, the liver is going to push out something, right? So the liver is going to be pushing out VLDL. All right. Now, what we saw in the intestine was that in order to form the chylomicron, we needed the apoprotein B48. All right. Now, in the liver, when the liver is making the VLDL, it's going to join it to apoprotein B100. All right. So anything, okay, so the VLDL, right, will eventually become IDL, then become LDL, right? So all those guys are going to have apoprotein B100 because they came from where?
Liver.
They came from the liver, right? All right, so the chylomicron, the free fatty acid bound to albumin, goes to the liver. Now, once you're in the liver, right, or once they're in the liver pushes out VLDL. All right, and the VLDL is going to have apoprotein B100. All right, does this make sense so far? Who does not get this? All right, okay. Okay, so then the VLDL is now in circulation, right? So as the VLDL is moving, the tissues in your body, they secrete lipoprotein lipase, and the lipoprotein lipase will actually extract free fatty acids from these guys as they move through circulation, all right? Now, so we have VLDL, IDL, LDL, right? But what about HDL, right? So HDL is made also by the liver, right? So the VLDL, IDL, LDL is transporting free fatty acids or cholesterol from the liver to tissues, right? From the liver to tissues, right? Now the HDL is transporting cholesterol from the tissues to the liver, but the HDL is made by the liver, all right? So another way to think about this, so the H could be, you can think of it as headed to the liver. That's a mnemonic, so headed to the liver. So HDL is produced by the liver and also by your intestine. Did everyone get this? All right, cool. So we're going to repeat this again. Okay, that's the way you learn. At least that's my philosophy. Okay, so your intestine, right? So we are going to have free fatty acid, right, and cholesterol. What else is gonna combine with this? What else is combining with these guys?
APB48.
Perfect. APB48. So we have the. Let's see. Let me get a good pen here. So we got the free fatty acid, cholesterol, and then apoprotein B48, right? So this is what then? What does this make? Chylomicron, right? And then the chylomicron enters your lymphatic system. From your lymphatic system, it enters what? Circulation. Now in circulation, cells are gonna secrete lipoprotein lipase, and it's gonna be like on the endothelium. So this lipoprotein lipase, not hormone-sensitive lipase. Hormone-sensitive lipase is for the adipocyte. It's only for the adipocyte. Lipoprotein lipase is for other cells. So lipoprotein lipase is gonna this enzyme is gonna extract the free fatty acid from the chylomicron, and as it does that, then we're gonna be left with the chylomicron remnant, right? So it's the remainder, right? And that heads to the liver, right? Okay, so we said that we're getting the fat from the chylomicron is going to the liver, and then from the adipocyte, right? We're having the free fatty acid that is bound to what? What is it bound to?
100? Oh, no.
That was from VLDL. So I'm saying, like, from the adipocyte, the free fatty acid is moving to the liver, but it's bound to what?
Albumin.
Albumin, that's right. Okay, so that heads to the liver. So once these guys once they come to the liver, now the liver has all this fat or whatever, the liver is now going to push out what? It's going to push out what? VLDL, right? And the VLDL is going to have what apoprotein?
B100.
Okay, cool. So it pushes that out. So we're in the liver right here. The liver pushes out VLDL. It has what? Apoprotein, what? B100. That's right. So VLDL is moving in circulation and moves through the action of lipoprotein lipase, right? The fatty acid is removed from the VLDL, then you get IDL, right? From IDL, you get LDL, right? And then from LDL, this guy returns back to the liver, all right? And also non-hepatic tissues. So I'm supposing maybe effuses or whatever. All right, does this make sense? Yeah,
okay,
go ahead.
The only part where I got a little shaken up at was when you said at the intestines. So you're taking out free fatty acids and cholesterol? What's actually?
Honestly, I mean, you're gonna absorb. Well, maybe let's put it. Well, when you're packaging the chylomicron, right? The chylomicron is gonna have cholesterol in there. So, I mean, where else could it come from but what you ate? You see what I'm saying? Yeah, sorry, go ahead.
When you're eating, this is the way it's like drawn in the diagram. You're basically having it so that you do VLDL, lipoprotein lipase, and that turns it to IDL. I thought that's what you said, but the diagram shows that they're both going to fatty acids.
No, so basically, as this is moving in circulation through the action of lipoprotein lipase, right? The free fatty acid, fatty acids are removed from the VLDL, and of course, like it's going to decrease in content, and then it's going to turn into IDL.
Okay.
And then as the fatty acid is more of it is removed, then it's going to turn to LDL.
Okay.
Does that make sense?
Yeah.
But it's through this guy acting on it to remove the free fatty acid.
Okay, it's like kind of like a layering process. You take one
Exactly.
So
Right.
it's
Yeah.
basically triacylglyceride being removed to transform VLDL to IDL to LDL, essentially, like with fatty acids are being removed.
Yeah, you can see it that way. Yeah. Okay.
Mind if I-
Yeah.
It's fine now.
Well, no, but what
I
were
was
you gonna
thinking
say?
of taking a picture of that Zoom meeting
I'm gonna send you guys. I'm gonna send you guys this document.
with
The edited stuff?
with the notes.
Not with well, not with what I'm writing on here
Well, if you
because
record it, you can, he's recording, so you just take a screenshot.
Oh, okay. Sorry about that.
you're fine. Okay, so we're gonna repeat this again. Okay, so we have dietary fat, cholesterol, right? So that was what you're saying. So it's going to move through your intestine. It's going to be absorbed by what? Your enterocytes. Your enterocytes are going to join that with apoprotein B48, and that's how you create your chylomicron. Chylomicron is going to move through circulation. As it's moving through circulation, free fatty acids can be removed from it, right? Through the action of lipoprotein lipase. All right? And at the end of the day, you're going to have the chylomicron remnant, right, which is going to return to the what? The liver, right? Now, also, the adipocyte, right, it can break down as triacylglycerol, free fatty acid bound to albumin, goes to the liver, right? Then once these guys coming to the liver, these fat content come into the liver, once it gets to the liver will now package them as VLDL, all right? VLDL leaves the liver, all right, and the fatty acid content is going to be removed from this VLDL via lipoprotein lipase. It's going to turn into IDL, then it's going to turn to LDL. Now notice that IDL can return back to the liver and LDL can return back to the liver or actually enter into the tissues. Cool. Are you guys okay with this? Now, in order to get this free fatty acid from the triacylglycerol that's inside the adipose tissue, what hormone is responsible? What hormone does this? All right, that's right. Hormone-sensitive lipase. So hormone-sensitive lipase is for the adipocyte. Lipoprotein lipase is for other cells. Cool? All right, let's make this a little bit clearer. Okay, so what we are seeing, so what we're imagining here is that this is a cell. All right. So it turns out that the lipoprotein lipase, right? All right, it's actually being secreted from the cell. So it's actually being secreted. So maybe this is lipoprotein lipase, and it is secreted out from the cell, all right? And so this is it right here. So it's just on the surface of the endothelial cell membrane, and it's bound to heparin. So basically, the VLDL coming from where? Where's the VLDL coming from? The liver. So VLDL, then you get what? From IDL, you get what? Okay, cool. So VLDL is in circulation, and as it's moving, so it encounters a lipoprotein lipase that has been secreted by the cells. And lipoprotein lipase is just like, it's literally on the surface. So this guy can act on the VLDL. Now mechanistically, I don't know how this happens. I'm just taking a guess. So it's going to release the free fatty acid. So again, if someone knows how it happens, please say, or forever hold your peace.
Something to do with like the C2, apoprotein C2 on the ends of the VLDL interacting with the sensor fibers of the LPL, and then it interacts, and that's how it does it.
Okay.
It's not really important. It seemed like a minute detail, but it was on one of the slides at one point in our labs.
Okay, I think I have it on here as well, so we will see that shortly.
On the very first slide you posted about it, like you put apoprotein 48 or 100s.
It's apoprotein C2.
C, and then slash, yeah.
Oh.
Okay, yeah, so once the, sorry, was someone else going to say something? Yeah, so once the free fatty acid is removed, it can go into the cell, right? And then stored or whatever, used for energy. Okay, cool. So just quickly looking at the lipoproteins. So this is just showing you a diagram of the lipoprotein. So structurally, so it's like a sphere, right? So you have like the outside shell, and then you have like the inner content. Everyone can see this, right? Okay, cool. So the shell, or the outside of the sphere, is made up of what? Phospholipids. Then we have cholesterol, and then we have the apoprotein. So this is apoprotein B100. So where is this coming from? Liver, right? Okay. So inside of it, we have triacylglycerol and cholesterol. You want to see it? Triacylglycerol inside, and then cholesterol inside, or cholesterol esters. All right. Now, so it turns out that everything, or at least according to what Dr. Sutherland has in his slides, so everything is going to have apoprotein C2. All right. So that is your chylomicron is going to have it. Your HDL, VLDL, IDL, LDL, all those guys, they have apoprotein C2. So what exactly is apoprotein C2? All right. So the apoprotein C2, it allows the lipoprotein lipase. So I've already forgotten your name. Sachin. Okay. What Sachin was saying. So this allows lipoprotein lipase to bind to whatever you have, and then release the free fatty acid. Cool? Did everyone get this? Yes? Okay. Okay, so this is just going into a little bit on the utilization of the lipid content. So what we established just before this, so we established how we're getting the lipids into the circulation. So we got the chylomicron, free fatty acid bound to albumin, going to liver, VLDL. So these guys were putting like fat content in the plasma, right, whatever. So how are we actually going to utilize this lipid content? So that's the thing. How are we going to utilize it, right? So it depends on the conditions, all right? All right. So if after you have a rich meal, basically your body is going to want to store that energy. So as soon as you eat and stuff like that, you're going to release insulin, right? Your body wants to store the energy. This is going to activate your lipoprotein lipase. All right, so what is the lipoprotein lipase doing for us again? Sorry, someone can I get? Okay, that's right. All right, so but just I guess just for you guys to know that insulin is activating this lipoprotein lipase. All right. So the lipoprotein lipase will remove the free fatty acids, right, from the VLDL, IDL, LDL, and chylomicron. And so basically, okay, so like you eat the food that goes in your intestine, is digested and stuff like that. All the I guess the fat and stuff, we get the chylomicron, and the chylomicron goes to your liver. But I guess at the end of the day, what you want to do, you want to be able to store that content, and the insulin is going to play a role, because once you have the lipoprotein lipase activated, then you can remove the free fatty acid from the VLDL, IDL, and then that free fatty acid can actually enter into the cell and then reconverge as your triacylglycerol for storage. So the insulin, basically, it's going to be signaling for storage, essentially.
Question.
Yeah.
Well, like we always talk about the tag and it getting made back or reformed from the free fatty acids.
Yeah.
But we never really go over it in class. Is that something we should read in the book?
Well, it's not really all that complex. So normally the way they have it, so let me see if I can, so let's say this is a cell. So from my knowledge, so you would have, so let's just say this is your, so let's say this is your triacylglycerol, right? And let's just say this is your intestinal, your enterocyte, and this is the lumen of your intestine. Say this is the lumen of your intestine. Now, of course, triacylglycerol is not going to be there because, I mean, you have the lipases that are going to act on it, right? So like your pancreatic lipase. So this guy, by the action of your pancreatic lipase, all right, so he's going to be broken down. I'm not 100% sure, but I believe this is how it occurs. So it's broken down to like 2 free fatty acids and monoacyl glycerol. Am I right on this? I'm just cross-checking. 2 monoacyl, right? What should be monoacyl glycerol, right? And then basically, like, these guys can like move in, and then like once it moves in, like they can reconverge and like through the action of certain hormones or certain factors are going to act on it, and it's going to like reconverge to this. You know, then this can join with the cholesterol. All right, and then you have your apoprotein B48, and then you can form your chylomicron. So this is kind of like how, I'm just giving you an idea of kind of like how it would happen. So are you guys good on this? Cool? All right, so so during, when we eat a meal, we basically want to store that energy, and insulin is going to be what we're going to be using. And insulin is going to act on your lipoprotein lipase to release free fatty acids. Now, during fasting and low sugar, So essentially, your body now wants to mobilize your energy resources. We don't want to store anything now, all right? So what we actually want to do, all right, is to increase blood glucose, all right? And what's going to be signaling for this is your glucagon, epinephrine, acetylcholine secretion. All right, and this is going to activate your hormone-sensitive lipase. All right, so there's two lipases, lipoprotein lipase. So lipoprotein lipase is mainly like signaling for storage. All right, hormone-sensitive lipase is signaling for like we need energy or like. I mean, I don't know if this is making sense. So are you guys kind of like getting where I'm going at here? All right, so the glucagon is going to activate your hormone-sensitive lipase. All right. Now, the hormone-sensitive lipase, we said, is acting in your adipocyte. And as the hormone-sensitive lipase is acting in your adipocyte, you're releasing free fatty acid. And that free fatty acid can now be used to supply or increase the blood glucose. Cool? Right? And the free fatty acid is transported to your liver, and it's bound to albumin, right? And then inside of your liver, you can do gluconeogenesis, which will result in the increase in blood glucose. Cool? All right, so hormone-sensitive lipase is activated by what? What activates hormone-sensitive lipase? Okay, so glucagon, epinephrine, and then what? So adrenal corticotropic hormone, right? Okay, so hormone-sensitive lipase is found where?
Inside adipocytes.
Okay, so in the adipocytes, right? So we're using the hormone-sensitive lipase when we don't have enough like glucose in the body, or like we're fasting and we don't have enough nutrients in the body. So the hormone-sensitive lipase is activated by the action of glucagon, epinephrine, adrenal corticotropic hormone. So lipoprotein lipase, what activates it? Okay, insulin activates it. And where can we find these guys?
Surfaces of cells.
Yeah, so they're going to be secreted, and then they're going to be on the surfaces, like endothelial surface. Okay, this is kind of just showing you guys a little bit on how lipoprotein lipase is acting. So when you have your triacylglycerol, lipoprotein lipase will actually break it down to diacylglycerol, and it will also break it down again, and then you would have your 2-monoacylglycerol. And in all these steps, you're releasing free fatty acid. Now, it's not going to break it down any further from here, right? You're gonna have something else acting from here to here to turn it into glycerol. Once all the free fatty acid is released, right? Then so we said that the lipoprotein lipase was outside the cell, right? So these guys are acting outside the cell to break this down. You have the free fatty acid outside here. Now the free fatty acid can just go through the plasma membrane, right? I'm not 100% sure, but I believe this should also go through. And once they're all inside, they can just reconverge, and you can have your triacylglycerol inside the cell. Do you guys see that? Cool. All right, so again, just another repeat on the apoprotein. Apoprotein B48 is made in the intestine. You only see it on your what? Chylomicron, right? Apoprotein B100, right, is made in the liver. So where are we going to see apoprotein B100? Where are we seeing that? Okay. And then how about the C2 on everything, right? Okay, cool. So that should help you guys to kind of like have an idea like memorizing this because it's a little bit daunting. Okay, so I did cover the whole. I put everything in the lecture in here, so I don't think I really missed anything from the lecture in here. So, but so another thing that Dr. Sutherland discussed in this lecture is a defect in the B apoproteins. Now, the two B apoproteins was what? What were the two B?
48, 100.
Okay, cool. So when you have a defect in the these B apoproteins, all right, you're not going to be able to make your chylomicron, nor are you going to be able to make the VLDL. All right, so you're not going to have the chylomicron in circulation. You're not going to have the VLDL in circulation. You're not going to have the IDL in circulation, yeah, so they're not going to be in your plasma essentially. So now let's think about this. So if you have all this fat, you're eating all this, cheeseburgers or hamburgers, whatever, fries, and this stuff is being digested by your stomach. It's going into your small intestine, and there's no way to push it into circulation. What's going to happen is going to back up, right, and it's going to end up in your stool, right? So you get what? Steatorrhea. You get fatty stool. Now you get muscle weakness. Why are you getting muscle weakness? Because when we don't have enough glucose in the blood, we mobilize the triacylglycerol from the adipocyte using hormone-sensitive lipase, right? Which eventually ends up in the liver, and then liver does what? Gluconeogenesis, and then we get glucose in the blood. So you'll get muscle weakness because you can't supply the muscles with enough glucose, right? You get decreased vision, mental problems because the brain depends solely on glucose for energy, except like when you're really, really fasting and stuff like that. And then you get neuropathy, right? And you also get red blood cell deformations. All right, so let me try to explain this. So your RBCs, right? They can only undergo anaerobic respiration. So they only do they only go through like the glycolysis. They don't do any like go through the electron transport chain. So like they don't have a mitochondria essentially. So your red blood cells are highly dependent on glucose, right? So in the case where we're not like bringing in fat or like bringing in the free fatty acids from our food because of the fact that we have this defect in the B apoproteins, again, like our gluconeogenesis is going to be impaired, all right? So we're going to be like hypoglycemic. We're not going to have enough glucose in circulation. So basically, the red blood cells is not going to be able to. So this is low. The red blood cell is not going to be able to generate enough ATP, all right? And if it's not able to generate enough ATP, now, so you have your sodium, potassium ATPase, right? So sodium, potassium ATPase. So we're pumping out what? 3 sodiums, right? And then we're pushing in what? 2 potassiums. Okay. So if hypoglycemic, low glucose in the blood, all right, red blood cell is solely it's using glucose as its main energy source, right? Anaerobic respiration. So we don't have enough glucose. We're not able to make enough ATP. We're not able to power this guy. Now, if we're not able to power this guy, what's going to happen is that sodium is going to accumulate in here. All right. If sodium accumulates inside the red blood cell, then what you can expect is that water is gonna move in.
So is that lysis?
Exactly. So the red blood cell is gonna burst. All right. Okay. Did everyone get that? Cool. Yes. Maybe.
Mm-hmm.
All right. Maybe something else just to point out for completion. I think we'll see this again. So epinephrine and so epinephrine, your glucagon, they're gonna be acting on a G protein receptor, right? So it's 7-pass transmembrane protein. is bound to a G protein here, and once it's activated, right? So the alpha portion is going to act on adenylate cyclase. Adenylate cyclase is going to convert cyclic AMP to it's going to convert ATP to cyclic AMP. Cyclic AMP acts on protein kinase A. Protein kinase A acts on the hormone sensitive lipase. So remember that the purpose of glucagon was to increase what? Glucose, right?
Yeah.
When we're in a fasting state. But what we have to do, we have to mobilize the free fatty acids that will go to the liver for the liver to then do gluconeogenesis. So this is just showing how the glucagon or epinephrine activates the hormone sensitive lipase to release the free fatty acid that will then leave bound to albumin, goes to the liver, gluconeogenesis, and then glucose will eventually end up in the blood. So yeah. Did everyone get this? Anyone have any question on this? So this is his whole lecture. I don't think I missed anything. So. Yeah,
Can
sorry.
you explain why there's muscle weakness again?
Okay, so essentially, so your muscles needs like constant like this energy. If you're not able to supply it with enough, like glucose or whatever, I mean it's just gonna be weak. Like after a certain time, like I mean you can only do, the muscles are only gonna be doing aerobic like respiration up till a certain point. Then it becomes anaerobic, and then if you don't have glucose, then what's gonna happen? Muscle weakness. Yes.
Is hypoglycemia also an effect of affecting the
So, yeah, you can see it that way. Yeah, I mean, if you don't have any, if you're not taking in fats, so it would ultimately result in that.
Also, like hypoglycemia, is it a cause? Is it a result of that the body's only using glucose and it's not able to utilize the fats for energy? It's like you lose that glucose sparing effect.
From what I understand, because of the fact that you're not creating these the VLDL, IDL, and your fats are not properly like moving throughout your body, you're not able to utilize gluconeogenesis properly. And if you're not utilizing gluconeogenesis, then that means like you're not going to have enough glucose during like fasting, like when you don't have any like food in your system.
So that's the only reason. That's what I meant. Like, I just want to know if it was something else. It was just gluconeogenesis or just that.
I mean, it could be. Again, my knowledge is not complete. I give you guys what I have understood. If someone has a laptop, they want to like look that up a little bit more, so we can get a little bit perfect understanding. Can you re-ask the question so
I
that?
just want to know. So you said, how is this body becomes hypoglycemic because gluconeogenesis is impaired. I wanted to know if hypoglycemia also results because you lose that glucose sparing effect of being able to utilize fats for energy as well.
I mean, possibly. I mean, I'm not 100% sure. Does anyone know the answer to this question?
So it has to do with ketones. So you spare the glucose because you want to save a little bit for energy for the nerves. The nerves are enraged. So then you use like ketones for energy instead. That's a glucose sparing effect.
Yeah, but the ketones.
From what I understand,
Yeah.
like if I'm seeing your question correct, I don't know about the glucose sparing necessarily, but it's just energy. It's just like the energy trade of like.
So
when
I
you
mean, like
lose
if
energy coming
you're
out.
not using that glucose sparing effect, then you're only using glucose. Like everything is diverted towards using glucose for energy. So by using more glucose, then you get hypoglycemia. That's what I was.
Oh, I mean, again, like, I don't claim to know everything. I'm giving you guys what I've understood, and again, like, I told you guys, like, I mean, I'm not going to be 100% correct on everything. So if you guys, like, if something I'm saying doesn't sound 100% right, just point it out, and we can discuss it, and then, yeah. Yes.
So I was just thinking, so at all times, whenever you're using the lipoprotein lipase, that's going to be used, the fatty acids that you get from there, and what else was that? The fatty acids, I think there's something else associated with that, but that's going to be used for storage, pretty much whenever you're using the lipoprotein lipase.
That's what I got from the slides. That's what I got from the slides. Yeah. I mean, I'm pretty sure, like, it's not, I mean, you know, again, in the body, everything's not black and white, you know, unless it can't work as a system. So, I guess for the most part. All right, so, so what I want you guys to do, maybe, like, we can take 5 minutes, and you guys can try to ask someone a question based on what we just talked about. So maybe like the person next to you, you can just try to, you guys can ask each other questions. And then if anyone wants to, alright, so if you guys can just put your question up there, and then like we can direct it to everyone else, and then you guys can tell us the answer at the end. So we can take like maybe 5 or 7 minutes, if that's okay. You guys.
I came in kind of late, but that's basically what you did on YouTube.
Yeah, but I completed the rest of it because it was only partial.
Okay. Well, which part did you not cover?
1 second.
So.
It's inborn error of metabolism, then we have carbohydrate. Carbohydrates. Okay, so I'm gonna list the conditions that were mentioned in the lecture. All right, or the deficiencies. Okay, so the first one was galactosemia. All right. Now, galactosemia. So you have, okay. So if I said viremia, that would mean I have a virus in the blood. Hyperalbuminemia, right? So I have albumin, you know, like a lot of albumin in the blood. So galactosemia meaning what? Like galactose in the blood. There's too much galactose in the blood. So there are 3 different kinds of this, right? All right, now with every single deficiency we're going to talk about, it's related to an enzyme deficiency. And when the enzyme is deficient, all right, you get an accumulation of, you know, that product that the enzyme was supposed to work on, and then you don't get any of, or you don't get any, or you get a little bit of what it was supposed to actually like produce. So there's 3 different forms. Now the one that was focused on in your lecture is classical galactosemia. All right, there was 2 other ones. She didn't really give a specific name. It was a she or he who presented. Okay, so she didn't like give the name of these. It's just like given by the name of the enzyme that is deficient. But the one that was developed in the lecture is classical galactosemia. Cool. All right. So then you have fructose urea. Okay. Perfect. That's right. So you got fructose in your pee. So if you had fructose in your pee, right, or that's not an appropriate word, right? Okay, you have fructose in your urine, so it must have been in your blood as well, right? Right. So, okay, so there are 2 different forms of this. All right, these actually have names. All right, so the first one was, let's see, it was fructose urea. Is it classical? I think it's classical. I think it's classical. I'll make sure just to check on this. Oh, it's essential. It's not classical. All right, so it's essential. All right, then the other form is hereditary. Fructose area. Oh dang, I've already forgotten this one as well. All right, intolerance is what that is. Intolerance. All right, cool. So we got galactosemia. There's 3 different forms. The major one that's developed in the lecture is classical galactosemia. All right, then you have your glycogen storage diseases. All right, now there are a bunch of these. There's a bunch of glycogen storage diseases, but for the purposes of this lecture, it was only 3 that was mentioned, and that's type 1, which is von Gurke. Then you have type 2, which is Pompeii. And then you have type 5, which is your McArdle. Cool. And then you have your glucose 6-phosphate phosphate or phosphatase deficiency. Okay, did everyone get this so far? Okay, so now let's just identify the pathways that these are coming from, right? So this is the galactosemia is coming from what? Galactose metabolism pathway, right? The fructose urea is coming from what? Our fructose metabolism pathway. You guys let me know if you can't see this stuff. I think just let me know if you can't see this stuff very well. So the fructose urea is coming from the fructose metabolism pathway. The glycogen storage diseases is coming from glycogen synthesis or glycogen metabolism pathway, right? And this glucose 6 phosphatase deficiency is coming from, oh wait, glucose, I think I'm saying this wrong. One second. It's either that or I'm forgetting one. I think I'm forgetting one of them. Okay, it's glucose 6 phosphate dehydrogenase. I did not. I'm confusing this with von Gurke because that one is glucose 6 phosphatase. So it's a little bit. Yo, it's too many enzymes. I'm telling you honestly, it's too many enzymes. Like, okay, so glucose 6 phosphate dehydrogenase deficiency, and this is coming from your hexose monophosphate shot. All right, so is everyone good on this so far? All right, is everyone good on this so far?
The hexomonophosphate shunt?
Yeah. Yeah. Okay, so what I'm gonna try to do now is we're gonna try to look at all these pathways together. All right, and we're gonna consider as we go through it, we're gonna consider the key enzymes, and then you know, again, if you guys want to add anything, feel free to add whatever you want to add, just to make this a little bit of a richer experience. And I try to get you guys to contribute as much as you can, because this session is it's going to be more effective if you guys contribute. Like, if you guys contribute what you know, and that's gonna, I can establish a foundation, and then you guys can build on it with what you guys know. Like again, I'm not spending weeks going through this stuff. You know what I'm saying? You guys are like literally the ones like really studying this stuff. So I can benefit. Like, I can benefit because I'm also a student and I'm trying to learn, right? And you guys can also benefit, right? So. Okay, so let's try to tackle this. Okay, so you got a cell, all right? And you got glucose outside the cell, and the glucose is going to enter the cell, right? Now, once glucose enters the cell, so 1 second, let me duplicate this because I'm going to. Okay, so you got glucose outside the cell, all right? Glucose enters the cell, all right? Once it's inside the cell, it needs to be trapped, all right? If it's not trapped, it's gonna leave, right? If you want to trap the glucose, you have to use either hexokinase or glucokinase. Now, there's a difference between these two guys, all right? So your hexokinase is in every cell, right? But your glucokinase is only going to be seen in your liver. Now, one way to remember this is that the L in glucokinase is for liver. So hexokinase, every other cell, glucokinase in the liver. All right? So once the glucose enters the cell, it has to be trapped. If you're talking about like a muscle cell, so what will it be using? What will the if I'm a muscle cell and I just hexokinase. So, but if I'm in the liver and glucose just came in, I'm not using the hexokinase. I'm using the glucokinase, and I trap the glucose as glucose 6-phosphate. All right. So I attach the phosphate group, and now I got glucose 6-phosphate. All right. Now I have the enzymes for the critical steps. So from here, you have an isomerase. Wait, is it an isomerase? You guys correct me if I'm wrong. It's an isomerase, right?
Mm-hmm.
All right. So you have an isomerase here. I'm not giving the specifics. So, but this is a reversible step, right? This is not a reversible step. This is a reversible step. This is not a reversible step. You got the isomerase, right? That's going to convert the glucose 6-phosphate to fructose 6-phosphate, right? Once we have the fructose 6-phosphate, now we have our phosphofructose kinase 1, right? And if it's a kinase, it's adding what? Another phosphate group, right? So now from fructose 6-phosphate, we get fructose 1,6-bisphosphatase. So we just add another phosphate group on what? The first position because of what? PFK1, right? PFK1, fructose 1,6-bisphosphatase, right? Now we have PFK2. So where do you think is going to add the phosphate group? 2. That's right. So we get over here is PFK2 acting on fructose 6-phosphate. We get fructose 2,6-bisphosphate. Okay, cool. So fructose 6-phosphate, fructose 1,6-bisphosphate, right? Then from there, it gets broken down to glyceraldehyde 3-phosphate or dihydroacetone phosphate, right? And then this step, it's going to be used. All right, so we got reversible step. We'll go to 1,3-bisphosphoglycerate, reversible step, 3-phosphoglycerate, reversible step, we get 2-phosphoglycerate, reversible step, phosphoenolpyruvate. Once you're at your phosphoenolpyruvate, then you get an, sorry?
Substrate phosphorylation.
Oh, for which step, sorry?
He's just saying that for PEP to pyruvate, that's substrate level phosphorylation.
Oh, okay, okay. All right, so from PEP to pyruvate, so we're having the enzyme pyruvate kinase as the enzyme that's causing this conversion. Now this is irreversible. All right, so there are 3 irreversible steps in glycolysis. All right, so the first one was hexokinase. Second one is PFK1, and then the third one is pyruvate kinase. All right. Now, just a little bit on, just going a little bit on, I guess the modulators, activators, inhibitors. So the pyruvate kinase is going to be stimulated by fructose 1,6 phosphate, and it can be inhibited by ATP. Why ATP? Because if we have enough ATP, why make more, right? If we have a whole bunch of alanine, well, it can be inhibited by alanine as well. I guess I'm not exactly, well, to explain it, it wouldn't make perfect sense, but alanine could inhibit pyruvate kinase. Cool.
Alanine, amino acid for amino acid corresponding for
You said alanine corresponds to pyruvate?
There was something that he said where like alanine was used, it goes into the cell and it like helps with pyruvate for something else, not for glycolysis.
So you're saying like alanine can be converted into pyruvate, is that what you're saying? Essentially. Okay. So did everyone get that?
I'm not sure if that's
You're not
correct.
sure? Okay. Okay. So I didn't know that, and that's good. So so alanine, we can kind of see it maybe as something that can feed into pyruvate or be telling us that we have a lot of pyruvate. So why make more, right? That would make sense. Okay, good. Okay, cool. So did everyone get this so far? Did everyone get this so far? All right, so what I want you to do, just on the sheet of paper, what are the 3 irreversible steps for glycolysis? Just write it down really fast. It's 1 minute. Okay, so those are the pathways that we're considering. All right. Did anyone is anyone confused on this? Did I lose anyone? Did anyone add something?
I think people want to go back.
Sorry.
Yeah, can you go back to that one real quick for a little bit?
This one?
Yeah, that one.
Okay. And you guys can talk about it, like, I don't mind. Just go ahead, feel free to talk about it. So I'll keep it on here for maybe, I haven't started.
Okay.
It's a good catch though. It's a good catch. Okay, cool. All right, so so we begin with galactosemia. So I kind of presented the pathway for the galactose metabolism. So galactosemia, right? You have a lot of galactose in what? Your blood, right? It's a disorder in the galactose metabolism. Now, what we've established is that there was 3 forms. All right, now I said that the major one that was extensively covered in the lecture is the classical galactosemia. There are 3 forms though. So you have one where you have a deficiency in the UDP galactose 4 epimerase. All right. You have one where you have a deficiency in your galactokinase. And then for the classical one, you have a deficiency in your galactose 1-phosphate uridyl transferase. Okay, Cool. I know that doesn't make sense, so let's see it again. So this is your galactose, right? It enters the cell. It gets phosphorylated. So once it's in here, it gets phosphorylated by your galactokinase, right? Galactokinase acts on it, and then we get galactose 1-phosphate. Now remember, when fructose got phosphorylated, it became fructose 1-phosphate. When glucose got phosphorylated, it became glucose 6-phosphate, right? Galactose 1-phosphate, right, is converted to glucose 1-phosphate via the action of your galactose 1-phosphate uridyl transferase, right? And so now your UDP galactose 4 epimerase is acting here, all right? And what it's doing is that it's converting the UDP galactose to UDP glucose so that the UDP glucose can be used by this enzyme to create this guy right here, glucose 1-phosphate. Yes, sir. Go ahead.
Oh, I mean, I was going to ask a question, but you made me jump in again.
Okay, but go ahead, dude.
I was going to say, for both of those enzymes, would they result in the same chemical being built up then?
Yes, that's exactly right. Except that this one will actually, this guy here will actually build this up as well, right?
Yeah.
Right. But that's a good point. Yeah. Okay, so what are the deficiencies here, right? So remember, we're talking about galactosemia, right? The deficiency is here. Here first. This is the first deficiency here. We got a problem here. We got a problem here. We're gonna have galactose. It can't get phosphorylated. So what happens? It moves into the blood. Well, it's not gonna be in the cell technically because it's gonna move back into the blood, right? So that's the first thing that we can happen. That's the first scenario: deficiency of galactose kinase. Second scenario is that we can have a deficiency here in this guy. So we will have a buildup of galactose 1-phosphate, right, in the cell, and also galactose, but then it leaves and it's in the blood. Does that make sense? Okay. Galactose 1-phosphate will build up because the enzyme is right here. So everything downstream is going to build up. I'm sorry, upstream. All right, I'm saying the wrong things now.
Does the galactose kinase stop functioning in that thing? Does it stop making galactose 1-phosphate?
I mean, it can still make galactose 1-phosphate, but at a certain point in time, I mean, I would suppose that it might be inhibited by maybe too much galactose 1-phosphate or something. So basically, everything, perhaps, but like you know, everything like that's upstream is gonna start like building up. Like just think of a traffic jam. You know what I mean? Yeah, everything behind it, yeah. Okay, so is everyone good? Okay, then we can have a deficiency right here, all right? Okay, so this is going to lead to a buildup of this, right, and then this, right? So now the classical galactosemia is with this guy right here. This galactose 1-phosphate uridyl transferase. This is classical galactosemia. So we said that there's 3 forms of galactosemia. There's one where it's UDP galactose 4 epimerase deficiency. That one is very rare, variable outcome, similar presentation as classical galactosemia. That's similar to what you were saying. Now we have one where galactokinase is deficient, right? If galactokinase is deficient, we don't phosphorylate, everything ends up in the blood. So you're not able to trap the galactose in the cells, right? Galactose accumulates in the plasma, right? Galactose in the plasma can be converted to galactitol. What's going to happen? So you can have this, you have the galactose, galactitol in your blood, and they can end up in your urine. The galactitol specifically gives you cataracts, and that's what we're seeing here. You guys see the cataracts, so you can see it here, right? So that's because of the galactose accumulation. Cool. So these were the two other forms, but this is the specific one that was focused on. Now notice that, well, actually, let's move on. Okay, so the for the galactose 1-phosphate uridyl transferase deficiency, remember, we're talking about right here. All right? You guys see this? Okay. So that's classical galactosemia. It's autosomal recessive. All right. So some of the presentations and symptoms during the first week of life for the patient. So you have poor feeding, vomiting, right? Lethargy. Again, so why would you have lethargy? Because this feeds into what? Glycolysis. So you're not getting enough energy production. You're going to have jaundice. You're going to have hepatomegaly. You're going to have neonatal cataracts, renal tubular disease. You're going to have hyperbilirubinemia, right? We're going to have raised ALT, that's which is an enzyme. We're going to have high urine amino acids, albuminuria, albumin in your urine, glucose in urine, and galactosuria. And this is from the slides, okay? All right, an increased incidence of E. coli sepsis. This was from the slides. And we'll try to make sense of some of these in a second. Okay, so let's try to get this straight. So if this guy is deficient, then galactose 1-phosphate is accumulating in the cell. Galactose is accumulating, but it's going to be like in the plasma, right? So we have accumulation of galactose in the blood. It becomes galactitol, right? And this causes cataracts. Because of the galactitol, you're getting cataracts, all right? This is also going to affect your brain. So these children are going to be like they're going to have mental problems. All right, so it might be slow. Okay, so we have accumulation of the galactose, and we're getting these problems. We also have accumulation of the galactose 6-phosphate in the liver cells. This is going to result in your hepatomegaly, right? So if you're getting all this accumulation, right, it's only going to be enlarging, right? So that's going to damage the liver, okay? So if your liver is being damaged, all right, so what the liver does is that when your red blood cells are broken down, so you're gonna have your bilirubin being produced. So bilirubin is a breakdown product of your. Once your red blood cells are broken down, you have bilirubin. Like it's one of the breakdown products. So bilirubin is cleared up by like your liver. So like, or it goes into your liver, and then your liver like conjugates it with stuff, and then it's used for other things. So now, if your liver is having problems, hepatomegaly and stuff like that, you're not able to clear up your bilirubin that's in circulation. So what happens is that the bilirubin, there's a lot more bilirubin in your blood. So the bilirubin is what results in the jaundice. You know what I'm saying? Because the liver is damaged, or you know what I mean, like it's not working properly, it's going to lead to impaired like clearance of the bilirubin from the blood. So it accumulates in the blood, and then you have your jaundice. So this is how we're getting this jaundice. And you can see this baby looks very yellow to me. I think he looks yellow. Okay, so now also because of this galactose 6-phosphate accumulation in the red blood cell, right? Red blood cell, you're getting this accumulation of the galactose 6-phosphate. So it's going to eventually lead to lysis, hemolysis of the red blood cell, because all this stuff is accumulating, And if it's accumulating, right, you had all this ions, well, not ions, but, you know what I mean, you got this substance accumulating. I mean, it's going to draw water inside, right? So it leads to hemolysis of the red blood cell. Now, if red blood cell gets broken down, then you're also getting bilirubin, right? And that's leading to jaundice, right? And then also accumulation of galactose phosphate, you know, also contributes to the retardation, but mainly the galactose is contributing to the retardation. Cool? All right, so we can kind of see yellow fatty liver. So we have failure to thrive. So again, like, you know, glycolysis, gluconeogenesis, you know, because the fructose feeds into it, failure to thrive. Brain white matter and neuronal loss. And then you also have edema. Okay, now the reason why you have edema is because of your liver. So your liver is responsible for producing a lot of blood proteins. And the blood proteins, it's going to be, it's responsible for maintaining like the hydrostatic and the oncotic pressures. You want that to be even. So, all right, I think I'm talking too much. Let me actually like. Okay, so this is your blood. All right, this is the blood, and you know, we're just assuming like these are cells or whatever. Let's do blood. All right, so this is like the interstitium. All right. Okay, so basically, as and if you guys need to leave, you can. So just feel free. Okay, so as blood is moving through the circulation, right? Some of the fluid can leave, right? Right? And enter into your interstitium. But then also, because of the fact that you have proteins present in your blood, right? These proteins are going to create an oncotic pressure that is bringing the fluid back into the blood, right? Because of the proteins. Now these proteins, so like albumin, right? We talk about albumin. So albumin is produced by the liver, right? And now if you don't have these proteins being produced sufficiently, right, then your oncotic pressure is going to be weak. So that means that the pressure that is drawing fluid back into the blood is weak. So what does that mean? That means that the hydrostatic pressure predominates, and if the hydrostatic pressure predominates, then you're going to get edema. And so that's where this is coming from. So this is traceable to this. Exactly. Does this make sense? Exactly. Okay, so because galactose feeds into glycolysis, you have less energy sources. We synthesize less glucose, contributes to mental retardation because what? Your brain is using a lot of glucose, right? Red blood cell lysis. Liver will try to compensate, mobilize fatty acids. You get hepatomegaly, jaundice, high amino acids in blood and urine. Okay, are you guys good with this? So diagnosis, check blood for galactose, urine for reducing sugars. Reducing substances is sugars. Treatment, you want to exclude galactose from the diet because it's the culprit. And lactose. So lactose is made up of galactose and glucose, right? Mm-hmm. So you want to use soy-based formulas.
So if you have a baby who has this issue, then instead of the mother actually breastfeeding, they would have to use some type of formula that doesn't have lactose in it?
Actually, mother's blood can do it. I think it's cow, like.
Oh, you can. So you can use breast milk, but you can't use like regular milk.
I think that's what she said in the lecture. It's like from a cow or a goat.
Oh, they don't have any lactose? The goat don't have no lactose?
Doesn't have lactose.
Okay.
Oh, so you can use goat milk.
What she said was that that's why sometimes that some mothers can breastfeed their babies, and then you won't know until they make that switch into introducing cow milk.
Okay.
substance. So you may not show that.
Yeah, go ahead.
So why is there glucose in here?
Why is it glucose? Okay, so if there is glucose in the blood, so what happens is that 20% of your blood flow goes to your kidney, and your kidney, like, you know, it sifts the stuff, right? So as it's going through like your glomerulus, right? Okay, I see. That's actually good. But
Galactose build up because there's not enough glucose. You said there were other things like because it wasn't converting glucose fast enough. Why
yeah, and why is it in the urine? Okay. Okay. So it doesn't seem like there's anything wrong with the glomerulus. So like, I mean, well, actually, that's actually a good question. Well, okay, maybe the simple explanation for that would just say because there's too much in the blood, it spills into the nephrons. But I don't know how.
Because like,
If you use galactose and you need galactose with sugar, put it on
because you
sugar
think that was
be
one of the reasons why
utilized.
there was lethargy because like you didn't
They don't
have
have
much
enough.
sugar.
If I'm not wrong, so I believe glucose is actually filtered into the Bowman's capsule and ends up in the proximal tubule and goes through.
It's back into the blood.
Hmm?
It goes back into the blood as soon as it gets to the proximal tubule.
Okay, good point. So now if we have too much of the glucose, galactose, being filtered into the glomerulus, entering into the proximal tubule, then we cannot, the renal tubular cells are not able to effectively reabsorb them, so it ends up in your urine.
And the galactose?
Yeah, that too.
So isn't it, because if it brings it back, you have even a more concentrated.
Wait, did I say, oh, okay.
So there's glucose in the
So there was glucose and galactose in urine. I was just trying to figure out how there was a buildup of glucose in the blood. That's all.
Oh, okay, I see your
I
point.
understand, like, I understand like the mechanism of how it gets excreted. I just don't understand why there's.
I got it from a certain source, yeah, I'm not, yeah. I got this one, I think I got this from a specific source, but it will be more so galactose here, yeah.
That sounds like
But
it's
yeah,
not-
I see your
If
point.
it can't, maybe the fact that you have a problem just impairs your ability to clear glucose as well.
I'm just trying to see if that was actually like.
Okay.
I feel like glucose is just kind of like a casualty of the defect. It's not necessarily.
But like if you're reducing one of the things that goes into, it's not really gluconeogenesis, but like something that like builds up glucose, because if you metabolize galactose correctly to make more glucose, right? So if you're not metabolizing galactose correctly, you're gonna make less glucose, which would normally mean that you're going to take away glucose, you're gonna get like hypoglycemia, or at least not like a huge amount, but like at very least like a little bit. So why is there I would assume it's like hyperglycemia, that's why you're getting the glucose in the urine. But it doesn't even say anything
Is
about
it technically hyperglycemia? Maybe it's just kind of like.
Reducing concentration of because if you keep bringing all those back in, it means your blood you will be more concentrated with that with the substance.
Okay. All right.
Maybe
Yeah, I mean,
your body's
I got it from a
just trying to
source, so I
clear
put it
sugar
on
from
there.
Your body, regardless of what kind it is.
Yeah, I got it from a source, so I just put it on there. Okay, so just quickly going through this because I have some mnemonics. So I'm gonna go through this quickly. I know you guys have an exam, so I'm just gonna quickly run through the rest of this. So again, so for the fructose metabolism, there's two forms. All right, so I'll be done in the next 20 minutes. Okay, so for fructose metabolism, there's two problems we can have, or two problems that's presented in the lecture. So we can have essential fructoseuria, and the enzyme that's deficient is your fructose kinase. All right. Now the fructose kinase, you guys already know, right? Fructose, and then it phosphorylates it, so you get fructose 1-phosphate, right? Fructose kinase is present in your liver and your pancreatic islet cells. All right. So what's the problem? We can't trap the glucose. So what happens if fructose builds up in the blood and the urine? Straightforward, right? It's less severe than the hereditary fructose intolerance. So it's relatively benign and asymptomatic for essential fructoseuria. Hereditary fructose intolerance is a little bit more it's a little bit more, it's far more serious. So the enzyme that's deficient is your fructose 1-phosphate aldolase. All right, now again, just going through this. So right here, fructose 1-phosphate, all right? That's catalyzed by a fructose kinase. This is essential fructose urea, right? Now fructose to glyceraldehyde dihydroacetone phosphate, that's catalyzed by your fructose 1-phosphate aldolase. And this is where we have the hereditary fructose intolerance, all right? Now notice that this guy is going to be more serious than this guy right here. Why? Because this deficiency here will lead to accumulation here and here, right? So this is going to be more serious. All right. So for the hereditary fructose intolerance, again, we have a deficiency in fructose 1-phosphate aldolase. Fructose 1-phosphate aldolase is found in your liver, kidney, and intestinal mucosa. All right. So again, I just pointed out what's accumulating, right? Fructose 1-phosphate is accumulating, and fructose is accumulating. So it turns out that the fact that you have fructose 1-phosphate accumulating actually inhibits your gluconeogenesis. So now the fact that this fructose 1-phosphate is accumulating, you are inhibiting gluconeogenesis. So what you're going to have for these babies, you're often going to have hypoglycemia. All right. You're going to have vomiting, hypoglycemia. So again, hypoglycemia is because we're inhibiting gluconeogenesis and also glycogen lysis because of that accumulation. Yeah.
Inhibiting those processes?
I was very curious about that. I wasn't quite sure how it did that, but yeah. I'm not 100% sure how it does it, but
because you probably don't have those reserves. You don't have those glycogen reserves built up, possibly.
I'm not 100% sure. Yeah.
Possible. So you're getting lactic acidosis. I'm not exactly 100% sure why, but if you have lactic acidosis, maybe it's like somehow depleting like your lactate.
I'm thinking.
So then you can't go into pyruvate for like everything else.
Okay, so I'm thinking. So the lactic acid. So it's probably okay. So yeah, that's actually. Okay, so lactic acid is what? Anaerobic respiration. I'm thinking it's some from anaerobic respiration. That's what I'm thinking. But again, the mechanistic way of how it happens, I'm not 100% sure. All right. So we're inhibiting gluconeogenesis. We're having fructose 1-phosphate buildup, fructose buildup, lactic acid buildup. Right. We're having hypoglycemia. Right. So now we're gonna have hepatomegaly, right? All right, and so the hepatomegaly. So you're gonna have fatty changes, and basically the function of your liver is gonna be impaired, and because it's impaired, it's gonna lead to jaundice, just like what I said before. Now this one is a little bit different because in this case you're actually gonna have portal hypertension and ascites. Ascites is basically edema. Ascites is edema. Now, the reason why, portal hypertension, what portal hypertension is essentially, so because there is, sorry?
Is hypertension in the portal vein?
Well, yeah, I guess it can.
Arteries?
Yeah, it can. Yeah, so maybe it can be from like maybe the veins in like that are going through the liver itself, because maybe like it's getting big, and then the veins in the liver itself is getting like compressed, and because of that results in hypertension, meaning like your heart is going to try to work harder to push the blood through, and that's going to raise your blood pressure. Like you're getting constriction within the vessels that are either feeding in, so the vein, the portal vein that feeds into the liver, and then you get your IVC going back to your heart, but like you have some kind of compression there, and your heart has to work harder to push the blood through, so your overall blood pressure increases as a result of that, and you get liver failure as a result of that. All right, so I'm just trying to run through the rest of this. So you also have sepsis, rickets, disseminating intravascular coagulation. So disseminating intravascular coagulation is related to the sepsis, essentially. All right, and then this is pretty straightforward. So you remove fructose and sucrose from your diet as a treatment for this. Cool? All right, so did you guys get this so far? All right, so this is the one I really want to show you guys because I actually got mnemonics for this, just as a way of helping you guys to remember these. So for the glycogen storage diseases, like what I said, there's 3 types. So you have your von Gerke, you have your Pompe, and you have your McArdle. So for the von Gerke, so let me see here. So it's a deficiency in your glucose 6-phosphatase. Remember, the glucose 6-phosphatase taking the glucose 6-phosphate and is converting it to glucose so it can leave outside the cell. If you don't have that, the glucose 6-phosphate is going to accumulate. Yeah. Sorry, it won't. Sorry, it's not able to leave the cell.
Yeah.
Sorry. Forward.
No. I had a question, but you answered it when you were talking.
Oh, okay. Yeah. So essentially, if you don't have this glucose 6-phosphatase, the glucose will remain in the cell and it won't be able to leave. Now, why is this critical? Because, well, if you're fasting or whatever, you got to have your liver release the glucose so that the cells in your body can be supplied, so you don't have hypoglycemia. So essentially, when you don't have this enzyme, your liver is not able to supply, glucose to the rest of the body. So glucose remains, like the glucose 6-phosphate remains inside the liver. So it's important to recognize that glucose 6-phosphate is only in the liver and in the kidney. So we're going to be seeing problems where you're going to have an enlarged liver and what? Kidney. Fasting hypoglycemia, why? Because what? You can't release that glucose. It's like it's there. All right. Acidosis, I'm thinking maybe because
Ketone bodies.
okay,
Yeah.
ketone bodies.
You go through the
Okay.
ketone cycle.
Okay.
It
Okay.
lowers your pH.
Okay. And then you have
Lipolysis.
okay. And then you have failure to thrive. Now, simple way of remembering this. So for von Gerke, so for von, think of one. Von like one. Von like. So you can imagine like one, right? Von, one, right? So the 1 is telling you that it's type 1, glycogen storage disease. So it's type 1. Now when you look at the G, so the G looks like a 6, so it's like glucose 6-phosphatase deficiency. So type 1 glucose 6-phosphatase deficiency. You guys get that? Okay. Now for the type 2, all right, this is what the acid maltase. Now the acid maltase is in your lysosome. So there was 3 different ways you can break down the glycogen, by removing the alpha-1,4, removing the alpha-1,6, and then sending it into your lysosome to be broken down by the acid maltase. All right. Now, if the glycogen that is entering into your lysosome is not being broken down, what's going to happen? It's going to accumulate in the lysosome. All right. So now, lysosomes, what? The lysosome is in every cell. It's in every single cell. So we're going to have every organ is going to be affected by this because every organ has lysosomes. But sorry, what are you going to say? Yeah.
Fat deposits in the skin.
Wait, what were you saying?
Is it the one with the fat deposits in the skin?
I'm not 100% sure. I'm not 100% sure. I'm based on what I saw on the slides. This is what I put. It's possible. I'm not 100. Does anyone catch that? So he was saying, does this cause fat deposits on the skin?
From nature, I don't know. I want to know sleep much.
All right. Okay, so
question?
Yeah, sorry, go ahead.
So acid maltase, there's a buildup of acid maltase because glucosidate's gone, so there's just a buildup of acid maltase, is that what you're saying?
That's where the deficiency is.
Oh, acid maltase is deficient. Like it's
Oh.
not working. So once the glycogen gets, so like 2% of your glycogen is broken down, inside your lysosome by the acid maltase, also called alpha glucosidase.
Oh.
So if the glycogen enters into your lysosome and the acid maltase is deficient, then the glycogen is just going to build up in there, right? So it affects all your organs. You get muscle hypertonia. You have cardiomegaly. Why? Because you have stuff building up in the heart, so it's going to enlarge, right? Now, if your heart is enlarging, now I don't know if you guys remember Sterling's law of the heart. The more you fill the heart, the better, like the more of push you're going to have. So if the space is narrowed, then your heart is not going to be pumping all that well because it doesn't, like, it's not filling well. If you don't have a good, like, if you don't fill your heart sufficiently, meaning like your end diastolic volume, then you won't be able to generate a strong enough contraction. So like, since the heart is enlarged, then the space in the ventricles are going to be smaller, so you're not going to fill well, so you're not going to like generate a good contraction, so it leads to heart failure. Then death before the age of 2. Cool. Now let me give you guys a way to remember this. Pompeii. So you can think of pop, right? You can think of pop. So what's going to pop is going to be like a bubble, some balloon, some circular thing, right? So that's going to remind you of what? Lysosome. So it's a lysosomal storage disease, meaning like things are accumulating in the lysosome. Every cell has a lysosome, so it affects every cell, right? Now there's 2 P's, right? So there's 2 P's. Now the 2 is going to tell you that it's type 2. It's type 2 glycogen storage disease. Cool? Okay, then the last one. These are the only ones that were covered in lecture. There's more glycogen storage diseases. Now type 5 is where you have a deficiency in your muscle glycogen phosphorylase. All right, I just want to quickly just reference this really fast. Okay, so going back here. Okay, so glycogen phosphorylase is necessary to break down glycogen into glucose. It's a necessary step. So if now notice this is muscle glycogen phosphorylase. All right, so this is specific to your muscles. So it's muscle glycogen phosphorylase. If your muscle glycogen phosphorylase is deficient, that means that your glycogen, like, you can't break it down. So you're not going to be able to use that energy source. Well, it can affect that, yeah, because if you don't have enough glucose, how can you generate contractions to begin with?
It'll be like muscle weakness.
Exactly. That's exactly right. So let's go back here. Yeah.
You get tired quicker.
Exactly. That's right. So you guys got it right. So you get muscle pains and cramps with strenuous exercise. Why? Because you can't break down the glycogen and supply the muscles with enough glucose, to generate the ATP to keep it going. Yeah, sorry.
So it's almost as if you're in a constant anaerobic state. Your muscles.
Does the lactic acid build up?
I mean, I wouldn't say anaerobic because, I mean, it's just that the energy reserve is not there. Because after a certain point, like after a certain point of exercise, the muscle switches to anaerobic. So the anaerobic is always given. You know what I mean? But I wouldn't associate it with
It's not,
anaerobic.
it wouldn't just be anaerobic.
Yeah, it wouldn't just be anaerobic.
It's more of like you're only able to use like creatine phosphate and like whatever little glucose you have like in the blood or whatever.
Okay, so we're almost through with this. Okay, so how do you remember the McArdles? So you think of muscle, somebody flexing their bicep. So the M for McArdle is like muscle, So it's a deficiency in the muscle glycogen phosphorylase. It's specific to the muscle. All right. Now this guy is actually missing his 5 fingers. Why? That's telling you that it's type 5 glycogen storage disease. All right. It's crazy, but it works. I'm telling you, it works. You remember this. I mean, if you look at it, you will.
Did you think about this?
Can you go
Huh?
back to the?
I mean, I like using mnemonics to remember stuff. It helps me.
Can you go back? Yeah. Can you go back to that for the last mnemonic?
Here?
Use the muscle.
Oh, okay.
Yeah, use that area. That's the right.
They're like back of mind. If you don't remember, you stop looking at the words.
So I have like an unrelated question.
Yeah, go ahead.
Thinking about for a while. What's the significance of the Corey cycle? And we were talking about like alanine and pyruvate.
Okay, honestly, I'll be honest with you. Okay, so I only prepare for these sessions. You know, you understand? Like, I only prepare for these sessions, so I would love to. Does anyone know?
I think it's the lactic acid.
It's kind of back. Wait,
It's,
Oh, yeah.
The
The
Corey
Corey
cycle is
cycle,
like lactic
Dehydrogenase?
you're going back from
Lactic acid to
pyruvate,
pyruvate
so then
to make
pyruvate,
glucose.
you can make glucose.
But then why
Because-
is alanine and alpha-ketoglutarate and glutamine in it?
Alanine and
Because
a couple
they're-
of amino acids go into pyruvate.
Yeah.
All of the
So how
all
is-
of the amino acids find a way into the glycolysis, and so alanine.
I was
Not-
just saying
not
how
all
the,
of them.
Most of them.
so it was just saying how
There's
those
a lot
like
of
Glycine
amino
and
acids.
leucine.
Not all of them, but like in the general. You remember the picture that the guy drew yesterday?
all ones that
All
were-
most of, okay. Well, most of the amino acids find a way to go into metabolism.
That's just how the amino acids get in.
Yeah.
Thank you very much.
Yeah, no problem. No problem.
Thank you.
The kidney, only the kidney does water. It's filtered in blood.
Oh, I can.
But it's really